Assalamualaikum. I am Dr. Aksali, one of your mentors for this AKP course, and I welcome all of you to the first lecture of this AKP course preparation course. We are targeting your May exam, and I wish you all of the best of luck, and I hope so. This journey of yours with this MedPrep online platform will be wonderful, and you will learn a lot from this preparatory course, inshallah. So today, as you know, that is going to be our first lecture, and that is going to be towards your diabetes mellitus plus recalls. So we have devised these lectures just like that in this AKP, that we will cover the topic, and then we will do all the recalls of that topic in along with the theory in the lecture, so that you don't have to go separately in the different videos or in the different you can say the group discussions for these recalls. So as we are talking about the diabetes, so we will learn about all the theory about this diabetes, whether it's DK or the diabetic type 1 diabetes, type 2 diabetes, or the other types, and then we will cover all the recalls regarding that. And I have added almost all of the recalls up till your this May exam, because September exam is not present. It's very poor in the scenarios. They are just like one line, and so that's why it's not that much appropriate. So I have added almost all of the questions up till May 2024. Only September exam is left. That is 2 is not like it's not available in the proper form. Whenever it's going to be available, inshallah, we will also add those questions from the paper September, and also onwards from the January 2025 exams also, once it's been done. So let's just start with the diabetes mellitus. So when we label it as the hyperglycemia, whenever you are going to have the symptoms of the hyperglycemia, like the polyuria, polydipsia, nocturia, along with that and the weight loss also, you are going to have the random blood sugar level of greater than 11 millimole. Only then you will say this is your hyperglycemia. Or if you have this all the symptoms, but along with that your fasting blood sugar level is above 7 millimole, then you can label it as the hyperglycemia. But if you don't have any symptoms, only you are going for the random blood sugar level or the fasting blood sugar level, then what you will do that again the readings are same, that the random blood sugar level will be greater than 11 millimole, but you will take it on the you will measure it 2 times on the 2 separate days, so that you will be sure that this RBS is in actually is high as you are expecting. Similarly, if you don't have any symptoms and your fasting blood sugar level is above 7 millimole, then you need to confirm it, and you will go for 2 times on the 2 separate days. And then you will label it as the hyperglycemia. But if you have all the symptoms and along with that, your random blood sugar level comes out to be 11 millimole, that is straightforward your hyperglycemia. And with the symptoms, if your fasting blood sugar level is above 7 millimole, this is also going to be your hyperglycemia. So what could be the cause of these hyperglycemia? You know that the most common cause is going to be your type 1 diabetes mellitus, type 2 diabetes mellitus, and the MODY. MODY is called as the maturity onset diabetes of the young. So we will talk about all of these 3 causes of this hyperglycemia one by one. And as you know that the most regarding our periods pediatrics, the most important one is your type 1 diabetes mellitus. So we will concentrate and we will spend more time on understanding this type 1 diabetes mellitus. So when again the same thing, when you will label it as when you get the random plasma glucose levels above 11 millimole with symptoms, or you have the symptoms plus fasting plasma glucose is above 7 millimole, then you can say that this is your type 1 diabetes mellitus. What are the symptoms which we are talking about here? There can be change in the school performance. There will be thirst, and there will be weight loss, polyuria, polydipsia, nocturia, and the tiredness, lethargy, irritability. All these can be signs of your type 1 diabetes mellitus. And along with that, if you are having these sugar random or the fasting blood sugar levels, then you will label it as the type 1 diabetes mellitus. Then we have another important test that is called as the oral glucose tolerance test, OGTT. Nowadays, it's not been done, but still we do it where it is indicated. It is not indicated when your RBS came out to be above 11 millimole and you are sure that this is hyperglycemia. when you are in doubt, like your levels are borderline, like your fasting blood glucose level is about like 7 or maybe 6.9, something like that, or your random blood sugar level is about 8 or maybe the 9, and it's not falling into the category which we in of those readings which we just talked about, that if this is the cutoff value, if it's above 11 random blood sugar level, this is hyperglycemia, and the fasting is above 7. But when you are getting some reading which is in between, and you cannot label that, you don't know that whether on the basis of this reading I should label it as the hyperglycemia or not. Like if we for this fasting blood sugar level we talked about, it should be above 7 millimole. When you get only 7, or you get 6.9, 6.8, something like that, then you are in doubt that whether to label it as the diabetes or not. Then for the random plasma glucose, if it came out to be 8, 8.5, 9, then obviously it's in between. It's not above 11 millimole. That is the criteria to label it as the hyperglycemia. Then it is then the recommendations are that in that case, when you are in doubt, you can go for this OGTT test, that is oral glucose tolerance test. And what does it do? It measure how well the body can process a large amount of the sugar. So, and it is used when you have the borderline elevations in the fasting plasma glucose levels specifically. Then you will go for the oral glucose tolerance test to confirm it, that whether it is in actually hyperglycemia or not. And what you will do that before starting, like at 0 minutes, you will take a blood sample. After that, you will give the patient to drink the OGTT solution, which is containing basically 75 grams of the glucose in 5 minutes, and the patient will drink that, and then you will wait for about 2 hours, 120 minutes, and then again you will take the sample, and then you will, and on that sample you will go for the plasma glucose levels, and then you will compare that at the 0 minute and at the 1 minutes, what were the readings for these plasma glucose level, and then you will label it accordingly. So if at the when you at 0 minute you took this sample and your plasma glucose level is less than 6.0, and after giving this solution and after 120 minutes it's still less than 7.8, then you will label it as the non-diabetic patient. But if at 0 minute your blood glucose levels was between 6.1 to 6.9, and after this 120 minutes they are between 7.9 to 11.0, then you will label it as the impaired glucose tolerance test, which means that the patient is in process to develop the diabetes. But if at 0 minute your levels plasma glucose levels were above 7.0, and after 120 minutes they are above 11.1, then you will label it, this is going to be straightforward your diabetic patient. And this is important because you will get there are many questions in your past exams in which they have given asked about this OGTT, and also one is regarding this interpretation. They have given you the reading after this 120 minutes, and then they ask you what is the diagnosis, like how will you interpret this test. So that's why it is important to know about this oral glucose tolerance test. Then what other investigations we can do? That obviously we just we will go for the glucose random, or the random blood glucose level. Then the electrolytes we have to check for that pH, and the ketones pH. Obviously we need to know that whether the patient is in the diabetic ketoacidosis or not, and the ketones level. Then HbA1c to check like how far this is diabetes is how long this diabetes is going on, and if the last 3 months your blood sugar levels are high, it means that your HbA1c will be also high. You can go for the full blood count to currently know that any infection is going on or not. Then the cholesterol or the triglyceride levels, and your this thyroid profile, because at the as the baseline when the patient is first time diagnosed, you need to check their thyroid as well as your celiac. You need to screen them for the hypothyroid and the celiac disease, because they have the association with this diabetes mellitus. So that's why you need to check at the baseline, like at the diagnosis, and then accordingly whether yearly or 3 yearly or something like that. Then we have the autoantibody screen for the thyroid and the C for the celiac, and these are the GAD and the isolate cell antibodies for your type 1 diabetes mellitus. Glutamic acid, this antibody. So these are the ones which you will go for that, but the most important is going to be your random blood sugar level and your HbA1c along with pH and the ketones. And then these are for the associations, you can go for that. But they have also said that do not arrange a fasting blood glucose level or the glucose tolerance test. If you get this RBS in your hyperglycemic range, in your diabetic range, then you don't need to go for any fasting blood glucose level or any glucose tolerance test. So that's why wherever you have this like question in which they have asked about given all the signs and symptoms of diabetes, and they ask about the first line investigation. So first line investigation will be your random blood sugar level. And if it came out to be equivocal or you cannot like label it on that, then you can go for the oral glucose tolerance test or the fasting blood glucose level. But we don't do this in the children, and only in the dire need then we will go for the fasting blood glucose level. Otherwise we will just go for the random blood sugar levels. Then how you are going to manage this diabetes? Obviously you know that type 1 diabetes is because of the insulin absent the patient's pancreas is unable to make any insulin. So there is deficiency, so you need to put the patient on the insulin. And what should be total daily dose of the insulin? There is a range given in the pediatric population, and that is between 0.5 to 1 unit per kg per day. Depending upon the age of the patient, you start this dose. And what are the insulin regimes which we have? Number one and the most important and the most recommended one is your basal bolus regime. And what is this basal bolus regime? Basically one is basal bolus, you just give the patient at night, and that is of your long acting. So in the evening you give them a basal bolus of this long acting, which means, and long acting means this insulin is going to work in the background for 24 hours. So you will give them at night or at evening like 7 p.m. Then the next day again you will give them this at the 7 p.m. So this is called as the basal regime, or which means you have make a background insulin. You have given them the patient a background insulin, and which will work all around like 24 hours to manage this hyperglycemia. Along with that, you will give them the boluses of 3 times pre-meals short or the ultra short acting insulin bolus, like before breakfast, then before lunch, and then before dinner. So this becomes 3 boluses. So we have this basal of the long acting insulin in the evening, and then we have the 3 boluses pre-meals of short or ultra short acting insulin. So before a meal, whatever the patient is consuming, whatever the amount of the carbs he or she is consuming, he will calculate those carbs, and then he will calculate the units according to those carbs, and he will or she will inject those units of this short or the ultra short acting insulin before meal, whether it's breakfast, lunch, or your this dinner. This is called as the basal bolus regime. Then we have the split or the mixed regime. It is also called as the like BD regime, because in that we use the intermediate acting insulin and the short acting insulin. And of the total daily dose, whatever the total daily dose is, we divide that daily dose into the 2/3 and the 1/3, and we take 2/3 of the intermediate acting. Like suppose if its units are becoming like 10 units is the total unit per day, according to the we have calculated. So among that 2/3 we will take intermediate acting, like about it will become about like 7 units. So we will take these about 7 units. So we will take 7 units of this intermediate acting. This will become 2/3, and remaining 1/3, that are the 3 units, we will take the short acting insulin, and we have to give them twice daily, in the morning and in the evening. So this is also called as the BD regime. Then we have the continuous insulin pump, which are basically using, these pumps are using rapid acting insulin as the basal is already set in the machine, and the bolus before every meal after counting the carbs with the button, just like that basal bolus regime. But in this case it is in the pump, which is just they have fixed it inside in the under the skin. And in that case, how do we, Dr. Dania is asking, calculate insulin requirement for the patient? Uh, Total, I have talked about this dose is 0.5 to 1 unit per kg. This is the actual which from which you have to calculate it. And if you are asking about the patient weight, yeah, this is 0.5 to 1 unit per kg per day. This is the dose. or carbs. This is the total insulin, 0.5 to 1 unit per kg per day, which you will divide them. Like if you are giving them the basal bolus regime, then this total unit, suppose the patient is 10 kg and you are starting them from the zero point 0.5, then total units will be only 5 units. And among that, if you are these are different regimes and you have the different calculations in that, but this is beyond the scope of your AKP. They are not going to ask you that this is the 10 kg baby and just give us the insulin basal bolus regime and calculate the units. This is not what they are expect you to know. That they just want you to know that whether you know about this basal bolus regime and how it does act. But if still you are interested in that, then suppose the baby is 10 kg and you are starting them from the this suppose we are starting from the 1 unit per kg, then total units will be 10 for the whole day. And if you are using the basal bolus regime, then 50%, you divide for the basal bolus, you divide them 50% is for the basal, that is the long acting insulin. So among these 10 units, if you take the 50%, that will be 5 units. So 5 units of this long acting, that is usually glargine, you will inject them in the evening, and remaining 5 units you will divide them in these 3 times pre meals. And along with that, suppose you get 2 in the morning, 2 in the evening, sorry, lunch, and the 1 in the evening. Along with that, you will calculate the carbs, and you will calculate the carb to insulin ratio and the insulin sensitivity index. So these are a long and you can say a long calculation which you have to and make the patient understand so they can calculate it by yourself. And then accordingly you will go for that. Yes, Dr. Dania, if you know that, then I think I don't have to repeat all these things. And because this is practical thing, and they don't want you to expect that you know in the AKP, or they're not going to tell you or they ask you in the exam. And similarly for the split regime, 2/3 intermediate, 1/3 short acting, and for the continuous, I have just told you that. And whatever I am telling you, this is according to your AKP exam scope. I know that many things are there which are practically we are doing, and we should know that. But the MRCPCH or this exam is, I will skip those things because they are not going to ask you in the exam. So that's why it does not mean I don't know or I not able to tell you. The thing is that this is beyond the scope of your AKP examination. And after you have this diabetes, sometimes in some patients, this is the thing is that the honeymoon period, there is a period of like about 3 months, maybe 6 months, depending upon the patient, in which what does happen that some of the pancreas function is still left for these patients. Once they get a period of this total insulin absence, and again, then they get some period of in which the pancreas is again start to functioning and again start to make some of the insulin. And in that case, their insulin requirement in these patients become very low, and sometimes you just have to stop the insulin. That is called as the honeymoon period, and that usually comes just immediately. Like if it has been like 3 months, 4 months, maybe 6 months, usually within a year these patients have this honeymoon period. But if the patient diabetes has become chronic, like 2 years, 3 years, 4 years, then this honeymoon period is not going to be there. It just comes immediately after, you can say, the patient has been diagnosed, maybe within months, not after like it has become chronic. So that's why this period, if it has to become in the patient, then it will come immediately in the immediate months after the patient has been diagnosed. Once the patient is chronically on this diabetic management, then it is less likely that the patient is going to observe this honeymoon period. There is some pancreatic function preserved after the first presentation of the symptoms, and that is called in which the insulin requirements are minimal during this time, and even sometimes you have to stop the insulin for a few like months, and you have to observe them. And once it is over and the patient is again going to have the hyperglycemia, then you have to start this insulin again. That is called as the honeymoon period. Then, what is the goal of or this management should be in these patients with the diabetes? The aim is to achieve near normoglycemia by intensive insulin management, Then along with that healthy eating, we have to tell them about that this traffic rules for eating, and the carbohydrate counting skills, which we talked about, that they have to check for the insulin sensitivity index, and then accordingly they have to calculate their carbs, whatever extra carbs they are taking, and then for those extra carbs they have to take the rapid acting insulin along with every meal. So you need to educate them about that. Only when you will go for this carbohydrate counting skills and along with healthy eating habits and the intensive insulin management, these three things, all these three things are going to be in line with each other, and then that is the where you are going to get a very good control of the diabetes. So what should be the targeted blood glucose level in these patients? It will be 5 to 6.9 millimole per liter. And what should be the target level of HbA1c? It should be less than 6.5%. And in millimole, it is 48. Usually they give you this in the UK, they use millimoles. So for the HbA1c, they also give you in this millimoles. So our target for the HbA should be less than 6.5%. That becomes 48 millimole per mole. And it is associated, this HbA1c target is associated with the reduced risk of the developing long-term vascular complications. And what about the glucose monitoring? Monitor the glucose levels at least 4 to 5 times a day. And one thing is that, or the one modality of this monitoring this glucose is continuous subcutaneous glucose monitor that is going to be used, which we just attach them subcutaneously, fix them, and it's going to use monitor the glucose for the patient. And usually nowadays the recommendations are that you should offer this continuous glucose monitoring to every patient who is going to be diagnosed with diabetes mellitus above 4 years of the age. But as it is not possible, everyone does not like it, or it becomes need to be patient need to be educated about regarding this you can say the management of this continuous subcutaneous glucose monitor, how to operate it, and the other hazards like the operative failure can be there, there can be local reactions, then the many other things are associated with that. So they recommend that you should offer to every patient who is diagnosed with diabetes mellitus, but it will be a choice that whether they want to go with that this monitoring or not. But one thing is that you should definitely do that continuous subcutaneous glucose should be used in children who are having with frequent disabling hypoglycemias or an inability to recognize or communicate them. So if the patient are having repeated episodes of these hypoglycemias, or the child is not able to even recognize, no matter you have taught them, you have educated them, but still they are missing these hypoglycemic episodes, and due to which they are in danger, or they are facing the quite consequences. In that case, you should give them, or you should counsel them regarding the use of this continuous subcutaneous glucose monitor. This is also a question past recall on this continuous subcutaneous glucose monitoring. And the patient should be aware that how to recognize the patterns of the high or the low blood glucose, or how to use the information to adjust the insulin dosages to achieve their glycemic target. So they should know about what are the signs and symptoms of the hypoglycemia and the hyperglycemia, and so that they can adjust their insulin dosages and they can treat them accordingly by themselves. Then what about fasting blood glucose level? What does they basically, when the patient is going to wake up in the morning, and they will check their early morning before breakfast, and they are going to check their blood glucose. That is going to be your fasting blood glucose level. And what does it will show you? It will reflect the action of the basal long-acting insulin. And if the patient has a pattern of the high fasting blood glucose, the basal insulin dose will need to be increased to bring the glucose level into the target. So it means that what was the basal insulin? It was a long-acting insulin, which we were giving the patient at night, at evening. So if you think, and it's going to work all like for 24 hours. So if after giving this, you have given them this basal long-acting insulin at night, and then in the next morning you check this blood glucose level before breakfast and they are high, it means that your this long-acting insulin is not enough, not sufficient, and you need to increase, because that's why you are getting this early morning hyperglycemia, and you need to increase this. So if the patient has a pattern of the high fasting blood glucose level, then what does it mean? It means that your basal insulin dose, that is the long acting, need to be increased to bring this glucose levels into the target range. In this case, I like to highlight one thing that is called as the Somogyi phenomena. In that case, there are difference between these two things, that whether your basal insulin is low or you need to increase it, or there is Somogyi phenomena. So what does Somogyi phenomena? What does we do that whenever you get this fasting blood glucose levels high in the morning, what you need to exclude this Somogyi phenomena. And how you will do that? You will go for the midnight these glucose readings between 12 to 2 a.m. You will ask the patient that at night they have to check the blood glucose, then in the midnight they have to check the glucose, and then early morning they have to check the glucose. And then you will monitor that how, what is the pattern. What is the Somogyi phenomena? Basically, it is that if you your if at the midnight you are getting hypoglycemia, and then in the morning this fasting blood glucose levels are high, these levels are high, it means that whatever the hypoglycemia you got at the midnight, in response to that your counter regulatory hormones, that is the growth hormone cortisol, they were released, and they caused the this early morning hypoglycemia. Okay, so this early morning hypoglycemia is in response to this hypoglycemia that is occurring at the midnight at between 12 to 2 a.m. So, and why this hypoglycemia at midnight was occurring? Because of this insulin, long-acting insulin, which you give them in the night. It means that your nighttime, this long-acting insulin dose is high. That's why you are getting this. Okay, I am confusing that here. Sorry, this is not the case. The thing is that you are having this hypoglycemia at the midnight, and in response to that your counter regulatory hormones were released to counteract this hypoglycemia, and they increase the blood sugar level. But what was the reason of this oh, what has happened? But what was the reason of this midnight hypoglycemia? The reason is that this is the short acting insulin which you are getting at night before every meal, because it's not long acting, because the long acting does not peak at like just after 4 to 6 hours. It takes about 8 to 10 hours to peak to cause this hypoglycemia. This is your short acting insulin which you are taking, whose like levels or whose peak levels reach between 12 to 1 a.m. And this is this short acting insulin which you are giving at this at night before every meal. This is the one which is the culprit here, and which is causing this midnight hypoglycemia, and in response to that you are getting early morning hyperglycemia. So in that case you need to decrease this short acting insulin at night, whatever you are taking before meals. This is also a question in your past exam, and this is the question in your Uh, this is not, this is quite controversial. Every time I just tell you, you just go with this long-acting insulin, you have to decrease that. If you go for the underlying the mechanism of action of your long-acting insulin, you will know that the long-acting insulin does not get peak levels within 4 hours. If you are getting it at the 8 p.m. and you will check at the 12 p.m., 12 a.m., midnight, and there is hypoglycemia, that is showing you this is Somogyi phenomena, and the early morning will be hyperglycemia. Your long-acting glargine does not peak levels. It even does not start to act within this 4 hours. So your long-acting is not the culprit here. You don't need to decrease the long-acting. It is the short-acting that is culprit here. If you just go to if you have you are in the FCPS or you are in the pediatric training, just go to the Wine Harris book and check the mechanism of actions of your rapid acting, short acting, long acting, and that when they are going to get the peak levels. This is here your short acting which you are having before meals at 8 p.m. and this is one which is going to peak at 12 p.m. and this is which this short acting which is going to cause this hypoglycemia midnight. So whenever you you are going to get this question, the answer will be you have to decrease the short acting insulin. You are not going for decreasing the long acting insulin. This is how this somogy phenomena is going to work. And in that case, you need to decrease the short acting insulin. But this is in the other case, if you are getting the early morning hyperglycemia, but there is no nighttime hypoglycemia, it means that this early morning hypoglycemia is because of this decreased long acting insulin dose at night. So that's why you need to increase that. And you don't have any hypoglycemia throughout the night, no reading of hypoglycemia. Just early morning fasting blood glucose levels are high. So it means that your nighttime long acting insulin which you have taken, it is you are taking in the decreased dose. So you need to increase the dose of this long acting insulin. So this is the difference between these two types of the scenario. And there are past questions that